and I'm a physician by training. And I have worked in the medical device industry since the year 2000. And majority of that, in fact, until 2022, I spent working for a large patient monitoring manufacturer in um, and helped bring a new platform of patient monitors into the market, which has been widely successful and occupies about 42% of the market share globally. So if I do a bit of a back of the hand calculation, I would estimate about 60% of the alarms being generated in ICUs around the world are currently being generated on monitors that I help to bring to market. So um, since I was part of the problem, I should also be part of the solution. And this is why we are discussing today how to get to a silent ICU. So let's look at what are the challenges in critical care alarm management in intensive care, and we'll see whether there's a problem. If there's a problem, is there a value in solving it? If there's a value in solving it, how do we get about it? Because getting from 0 to 100 is really tough, right? And then we will basically conclude this session and we'll have a Q&A. So let's look at the problem. What are the challenges in critical care alarm management? So we all know about alarm noise that the devices around the patient generate. That's part of the problem. The second part of the problem is alarm fatigue, the sheer absolute number of alarms that the nurses get during their shift, most of which is not actionable. And then, of course, not having the proper context to understand what those alarms are all about, prompting the nurses to run from whatever they're doing to the bedside. This has a lot of impact on the clinicians and the patients. So if you look at from the clinician side, the nurses receive a huge number of alarms per day. And it's a staggering number, right? Per patient per day. And out of that, about 80 to 95% are non-actionable. That means these are not false alarms per se, but alarms that are really not meaningful for a patient. So for example, let's take an infusion pump, right? When an infusion pump reaches, when it detects that the syringe is empty or close to being empty, it sends out a critical alert, a red alert, saying the pump, the syringe is going to empty. And it's really a critical alert if the syringe is infusing inotropes, because the moment inotropes run out, the patient starts to crash, right? It's really not a critical issue at all if the pump was infusing antibiotics, a bolus of antibiotics, and you can just swap out the syringe next time you walk to the bedside. But both those alarms go with the same priority, with the same urgency, but one of them is actionable and one of them is not actionable. So if 80 to 95% of the alerts that we're getting are not actionable, what we are basically doing is training our minds, training our brain to simply ignore that. So we would basically glance at a notification, acknowledge, and forget, because our brain is really good at that. Our brain is really good at adapting to these things. Right? But then comes the critical alert that we, during this brain fog, completely forget and is not attended, which can lead to patient issues. And we all know that, and it happens. From the patient side, WHO has actually recommended a certain level of alarm noise, and our ICUs far exceed that alarm noise throughout the day. And this is not just, let's say, normal ambient noise. These are alarms. Alarms are a special kind of noise. They're basically designed, by design, they break through your normal thinking process and alert you that there's something wrong. This is why alarm sounds are so annoying. They are meant to be annoying. So imagine you're a patient, you are sedated, you have no idea what's happening to you, you are semi-conscious, and these alerts, these sounds keep getting blasted into your ears. You actually, when you hear something like that, your body reacts in a fight or flight reaction. Your body produces adrenaline, produces cortisol, the stress hormones, and these are basically not the best things to have when you're trying to recover from an injury or from a surgery or from other emergency. So you don't actually need to be awake or conscious for your body to react this way, because these reflexes are not mediated by the neocortex. These are mediated by brain centers that are way below the neocortex. So even if you're sedated, your body still reacts to these things. And the unfortunate side effect of this is that if the patient is sedated for a long period of time, and if the patient is exposed to this noise throughout that time period, the patient's brain loses the day-night rhythm. The patient's brain loses touch with reality, and the patient wakes up with delirium. Delirium is a neurocognitive impairment that basically makes the patient think that they are in a different world. And this is not uncommon. Last year, my dad was admitted to the ICU with septic shock. He was sedated and ventilated for 10 days. He made it through. And all around him, the patient monitors that I helped to create were basically sounding out alarms, right? And when he woke up, he was in delirium. He couldn't recognize people around him. He couldn't understand where he was. He didn't even understand in which phase of his life he was. And he was discharged a couple of weeks later, but he never regained a lucid moment until he passed away a couple of months later, like most patients with delirium do. Delirium reduces the quality of life. It reduces the survival, the length of survival post-discharge. And even in those patients who recover some semblance of lucid thought, the incidence of suicide is much higher than in normal population. So delirium is a huge problem. It's something that actually results as part of this noise that we're generating. So is there a solution to this problem? Yes, the silent ICU. It's a technical reality. The technology to create a silent ICU exists today. It's not science fiction. In a silent ICU, what happens is that the devices around the patient switch off their audio. They still generate alarms, but they don't actually sound anything at the bedside. And these alarms are basically taken over by a reliable alarming system that can actually move this information from the bedside to a caregiver's mobile device and sound the alarm at the mobile device. So in a sense, taking the sound away from the bedside to where the caregiver is, because the patient can't do anything with an alarm, right? It's worthless sounding that alarm at the patient bedside when the patient can't do anything with it. We need to bring it to the people who can actually act on it. So one part of it is actually removing that sound from around the patient. The second part of it is actually reducing the burden on the caregiver, because we looked at it earlier. We said 85 to 90% of alarms so 80 to 95% of the alarms that a caregiver receives are not clinically actionable. And that leads to alarm fatigue, that leads to burnout. So that means there needs to be also a smart filtering system that identifies the clinical context around the alarms. Today, most alarm filtering systems just use the alarm urgency assigned by a device. And this is why, like in my previous example, an infusion pump, whether it's delivering inotropes or whether it's delivering antibiotics, will create the same level of urgency when the syringe is empty. But if we look at the context of that alarm, and if we look at the fact that the pump is actually delivering antibiotics instead of an inotrope, we could basically suppress that alarm halfway during the chain and basically not let it get to the caregiver's mobile phone. And that way, we can reduce those clinically non-actionable alarms. So that was actually a very simple example, but there are much more complex examples where by combining multiple parameters or by creating a digital twin of the patient and testing that alarm specifically on that patient himself, we can basically identify whether it's really actionable or not and take a decision within seconds whether to filter out that alarm or not. So these two capabilities is what really creates a silent ICU. So there's a problem and there is a solution. But is this problem really worth solving? Is there a value in solving this problem? So all of you who are clinicians would definitely say yes. What kind of question is that? It is worth solving. But to a hospital administrator, a part of the executive team, part of the C-suite, do they see this as a problem? Do they see this as a value? Do they see a value in solving this problem? And that's what we need to look at next. Is there a value in solving this problem? In healthcare, there's 5 different types of value that we can deliver. There's economic value, which is measured in money, which is basically direct savings or additional earnings. Then there's operational value, which is measured in minutes. It's how we can actually make processes run more efficient. It's about how much time we can save the nurses and the physicians. It's about how we can actually use resources more efficiently without wastage, like an OR or an imaging system, right? Then there's clinical value. Clinical value is about improving patient outcomes. It's about reducing adverse events. It's about creating situations where patients do not get discharged with disabilities. And then there's emotional value. Emotional value is basically bringing job satisfaction to the nurses and physicians. It's about reducing the irritations, the hassle, the factors that lead to burnout from that workflow. It's about improving the patient experience. And then there's societal value. Societal value is the lifetime cost the society bears in taking care of a patient who is sick. Part of the cost is the hospital treatment, but if the patient actually gets discharged with a disability or a neurocognitive disorder, that is going to cost the society much more in resources in actually helping that patient live an independent life. So these are the 5 different types of value that we can deliver in healthcare. Now let's look at a silent ICU and what kind of value it delivers. So economic value is actually nice to have because you can easily quantify it. And then the hospital administration will love you for bringing in additional revenue or reducing cost. So that's easy to measure, right? Then there's operational value, which is basically saving time, like I said, which can also be converted in that sense to money, because time is money. We can basically calculate how much of nursing time we save. We can talk about how much resources or resource wastage we reduce, right? Then there's clinical value, which is harder to measure because you need to basically put a value around, let's say, improving patient outcomes. Not hard, but then it's really harder to prove this because you need to have really studies that take out any bias. Then there's emotional value, which is very hard to quantify. I mean, yes, you make the nurses happy, but what does it do for me as the CFO of a hospital, right? So you cannot distill easily that into a financial benefit for the institution. Hospitals are essentially businesses in that sense, right? Societal value can be quantified because you can actually, for example, see what is the average cost of post-hospital care for a patient with delirium. And if you reduce the incidence of delirium, how much money you can save the society. To a hospital, that might not be so interesting because it's outside their boundaries. It's outside their financial boundaries, right? So let's look at the benefits that we mentioned, or the problem in the problem statements, the issues that we mentioned for silent ICU. So we mentioned that alarm fatigue is an issue. Clinicians can get desensitized. It can reduce their emotional satisfaction. It can increase the risk of patient harm. Where does it map in these buckets? What do you think? It maps into clinical value and emotional value. Clinical value, like I said, is hard to measure. Emotional value, like I said, is very difficult to quantify. Well, what about reducing delirium? Improving patient satisfaction and reducing delirium. How about that? Well, it tracks into clinical value, clinical outcomes here, emotional value for the patients, and societal value. So what's missing here? We don't see economic value, we don't see operational value. So if we don't see economic value and operational value, how do we go to our hospital management and say, hey, we need to do this project? Keep in mind, a silent ICU project is not easy. There's a huge amount of work to be done. If you're starting from the ground, there's a lot of things that needs to be put in place. There's a lot of changes that you need to make into the workflows. There's a lot of change management that you need to make. And this is going to take time. It's going to cost resources. And it's going to basically cost money. So how do you basically take this whole elephant and digest it? Well, there's an African proverb that says, the way you eat an elephant is in bite size, is one bite at a time. So we need to think about how do we cut this elephant into pieces that we can swallow. And this is going to be what I'm going to talk about in the next part of my presentation. How do we get to silent ICU, where we are independent projects that we can justify, where we can measure the success, and where we can show a quantifiable value? So how do we do this? Hospital digitization is a journey. It's not a single project. It's not a single jump from 0 to 100. There are steps in between, and we need to plan out those steps. So any good digitization journey begins with defining the goals and the strategy and what you want to achieve. So it needs to basically stretch to the horizon and dictate what you really want to see at the end of this journey. The end of the journey needs to be stated as a vision, and that vision needs to remain static. It needs to remain as the North Star guiding this whole journey through, right? Once we define the end goal, we need to define the steps that will lead to that particular end goal. And it's very easy to get lost because there's a lot of work to be done in the middle, and it's very easy to lose track of what your end goal is going to be. And that's very important. That's why we need to have this vision as part of the hospital digitization journey. If not, we end up with stuff that leads to dead ends. So how do we build this out? So if we look at this journey that goes from medical device integration, clinical surveillance, distributed alarming, smart alarm filtering, silent ICU, how do we build this into independent projects? Let's look at medical device integration. Medical device integration basically means taking data out of the devices at the bedside and feeding them into systems that can utilize that data. Most hospitals today have digital medical records in one form or the other. And in order to basically utilize the digital medical records or electronic medical records, you need to have data in those medical records. There's an advantage to having digital or electronic medical records because it's not like the paper charting, for which there's only one copy. Everyone can simultaneously access this data, and taking care of patients is not one person's job. It's a team effort. There's a cross-functional team that actually takes care of a patient in the ICU. So that cross-functional team needs to have the actual data, the most current data available to them at their fingertips in order to make the right decisions, in order to take the next steps. If we don't have devices interfaced to systems, you need to transcribe them. And that happens in hospitals with nurses bringing in a computer on wheels or a tablet and basically transcribing information into the system. Or sometimes if those resources are not available, you see nurses writing stuff down on the glove, going to a workstation later and keying in that data. So if that glove got smudged, maybe you'll see a number 6 as a number 8, and you key in the wrong data. And in any case, there's a delay in the data going into the system. So transcribing manually can lead to errors. It can lead to delays. Getting the data directly from the devices bypasses that step. It saves time for the nurses because you don't have to do these administrative tasks. It gets done for you. So The data is available with low latency. It reduces the workload for the nurses. That means through this project, we can basically test the hypothesis that actually putting in a medical device integration platform reduces the time spent on vital signs charting for the nurses, freeing up time for patient care. And we can easily measure that through a time and motion study. We can look at how much time people spend on documentation. And like I said, each step needs to lead to the next step. So that means when you're looking at implementing your first step, you need to look at how it influences the next steps. The medical device integration platform that you choose needs to be able to identify alarm information upfront and send them with low latency to systems that manage alarms. Because sooner or later, to get to silent ICU, we need to build a reliable alarming platform. And that means low latency alarms, that means reliable alarms. So there are multiple different ways in which medical device integration takes place. In some systems, the system just listens to the data coming out from a medical device, creates a package of data, and sends it through the network. In some cases, there's pre-processing. As soon as the data comes in, there's a sniffer that identifies this is an alarm and sends it through a low latency priority pathway to the alert manager. So this reduces the latency, because if you wait until data packets are built up, and keep in mind, for an electronic charting system, the data doesn't need to be real time. If there's 5 seconds delay, there's no problem at all. Data appearing 5 seconds later is not a problem for a charting system. But it's a huge problem for an alarm management system, because you get delays that you cannot compensate in the alarm chain. So the IEC 60601-1-8 standard, which governs distributed alarming system, state that the alarms need to get from the bedside device to a caregiver's mobile phone in less than 10 seconds. So there, every second counts, because there's also processing in between. There will be filtering in between. Right? So if we do this step, and we do prove, and if we can prove that this step reduces the additional work for nurses, it improves efficiency, it allows nurses to take care of more patients. What kind of value is that? That's operational value. So if you have an operational value, you go to the people for whom operational value is a KPI in the hospital. That is the chief operating officer. Of course, you will have your chief nursing officer and others sponsoring this project, but it's the chief operating officer who will provide the budget, because this is in line with the chief operating officer's KPIs. So that is where you find the money to do this project. That's how you do your first step. What comes after that first step? When data comes into the system, there needs to be another intermediate processing that basically puts together the patient context, something that interfaces to all hospital systems, including lab systems, including the physician order entry systems, including the medication administration record, to basically compile a full information about this patient, to sort of build a digital twin of the patient, so that in the future, the alarms can be filtered according to the context that we built for this digital twin. So here the problem, how do we bring something like this in? Because this is something that people won't see, right? How do we build that into a project where it actually generates a benefit for the hospital? If you look at general wards, in general wards, there's usually a high patient-to-nurse ratio, which means the nurses are not able to have a good situational awareness about their patients, because they see the patient only maybe once or twice during the shift. When every nurse is taking care of 6 to 10 patients, it's really hard to basically pay attention to the same patient, to build up a picture of their deterioration. Because of this, deterioration is often missed in the general ward. 1 in 6 patients in general ward suffer an adverse event. That's a huge amount, right? And these adverse events can result in longer length of stay. It can result in the patient bouncing to the ICU. which can cost a lot of money, and of course, increases the length of stay and blocks up the beds, reduces patient turnover. And if the patient actually has a disability, in the end, it also has a societal impact. So if we implement a system that actually takes the data that the MDI system is gathering, analyzes that data, and provides a situational awareness and a heads up to the nurses in the most affected areas like the general wards, saying that your patient is on a deterioration path, that means you can actually build a value out of that step. And that value can be tested. We can basically test the hypothesis that implementing a clinical surveillance system on top of the MDI can result in in deterioration being captured early, in interventions being provided early, resulting in a shorter length of stay and resulting in less ICU bounce backs. And if we do that, we can basically see, again, the value delivered is cost avoidance from reduction of ICU readmissions and reduction of length of stay. And that means, again, an operational value, and your budget comes from the operational budget of the hospital. And when you build a system like that, you need to ensure that that system is able to host the kind of algorithms that are needed for a future smart alarm filtering system that can reduce the alarms going to the caregiver's mobile device. That's one of the major components, right? It needs to have a notification interface which can actually spread the notifications about the deterioration happening to the patient, which are not alarms, but which are calculated, which are results of calculations that are performed on the data that is coming through. And it also needs to be able to create a digital twin of the patient and provide guidance to a future smart alarm filtering system on the situation surrounding the patient. So it's a lot of things that need to be done, but at the same time, for example, you need to basically make sure that the clinicians are equipped with mobile phones, because they are now going to receive these alerts on their mobile phones, right? The alerts created by the clinical surveillance system. You need to change the workflows and to take advantage of it. You need to basically, I mean, if you detect deterioration early, and if nothing happens, then you're not going to change the patient outcomes. So you need to make sure that the workflow is changed, and you need to make sure that this change management is done. So it's not an easy piece of work, but it needs to be done. And if we do this, we can move on to the next step. The next step would be a distributed alarming system. Who would this benefit? It would benefit the ICUs. So if you look at the new ICUs that are being designed, they are being designed as single patient rooms. This is a lesson learned from the pandemic. And when we call it the pandemic, but it's not going to be the last. So all hospitals are preparing themselves for future pandemics on protecting the patients from other patients, protecting the clinicians from patients. And so the way to do this is to build single patient rooms. The problem is, if the devices at the bedside are generating the alarm sounds, and if you close the door, you won't be hearing those alarm sounds. If you're not receiving those alarms to your mobile device, you will miss those alarms. So if you don't have a system where the alarms are distributed to the mobile devices, you're defeating the purpose, because you have to keep the door open so that you can hear the alarm sounds from the corridor. So that when a nurse takes care of 2 or 3 patients in an intensive care unit, they can hear the alarms from their other patients. So that means the risk of not hearing alarms can lead to patient events, and keeping the doors open defeats the purpose of building single patient rooms in the first place. That means by creating a near real-time distribution of alarms to the caregiver mobile devices can help the nurses take care of multiple patients in the ICU, and it can also help keep the doors closed. So again, this is a KPI that we can measure. If we actually build a system that delivers alarms with less than 10-second latency to the mobile phones of the caregivers, we can basically measure the impact that this basically brings to the nurses. So if we look at the value that is delivered, again, we are basically creating a forced multiplier, helping nurses take care of multiple patients in the ICU. And that means basically we are delivering an operational value. We are increasing operational efficiency. And again, the COO is your friend, because this is a COO KPI, right? You have your clinical sponsors, and you have the budget coming from the COO. Again, it's a project that has individual value, which you can prove. And that gives you the ability in the future to build, it gives you the ability to transfer alarms in less than 10 seconds to an alarm distribution system. And a reliable alarm distribution system can basically look for breakages within the system. It can basically track each part of the chain, from bedside device to the system, from the system to the alert manager, from the alert manager to the mobile device. All of these parts are things where things can go wrong. Somebody could pull out the cable from the device, and the connectivity stops. Somebody could basically go out of range of the wireless LAN, or go out of the range of coverage and not get alarms. All these things need to be monitored, and we need to basically have fallbacks in case that happens. So this is a thing that we need to have in order to build a silent ICU in the future. Now, the next step is also quite critical. The next step is building a smart alarm filtering system, not the device critical, the criticality-based alarm filtering that we use today. It's basically building a system where the patient context and the patient digital twin is taken into account when you are looking at creating actionable alarms or filtering out non-actionable alarms. And research shows that 35% of a nurse's time is basically spent on attending to alarms. And if 80 to 95% of these alarms are non-actionable, that means that time, 1/3 of that time is basically spent on reacting to nothing. And if we can actually put in a system, and if we can measure how much time the nurses spent on attending to alarms before versus after, and if we can show that this time can then be productively spent on patient care, then we have an operational value. So that means by putting in a smart alarm filtering system that uses protocol-based and uses machine learned algorithms to basically understand which alarms are not actionable and stops them in their tracks, can basically deliver operational values. That allows the nurses to take care of multiple patients. And that, again, my friends, is an operational value. So the COO, again, is your friend. So you know how to go to with all these projects, right? You know who will actually fund these projects. And hospital digitization, again, is an operational value from the beginning to the end. And what's the last step? The last step is the silent ICU. So we have integrated medical devices. We have created an analytics platform. We have created a reliable alarm distribution system. We have created a smart alarm filtering system. And the last step is to have the devices at the bedside go on audio off when they're connected to a reliable and functioning alarm distribution system. And that means we basically reduce the sound pollution at the bedside. We reduce the disturbance to the patient. We increase the rate of healing, and we reduce the incidence of delirium. And the incidence of delirium can easily be measured. And this is something that we could measure before and after the project to basically see the impact of the project on delirium. And if we actually look at the influence on the patient, it's the benefit delivered out of reducing delirium. It's a societal benefit. That means it's something that is coming. It's a value that is consumed outside of the hospital. It's consumed by the health insurance funds. It's consumed by the payers. It's consumed by the government. It's consumed by the Ministry of Health or the regions in some countries. And they are the ones who will fund this project. And keep in mind, these people take a long time to basically make up their minds about funding a project. So by the time you're already starting on the MDI step of the project, you should also basically start pitching this idea to the people who are going to fund this last step. Because believe me, it's going to take a long time. And once you get there, you have achieved your dream. You have a silent ICU. You have reduced the alarm load on the clinicians, and you have created a healing environment around the patient. And that's where we want to be. So what we have done in this exercise is to cut down all the steps that we saw that we need to do. I mean, the entire workload that we saw that we need to do in order to get to a silent ICU, we have cut them down into individual projects. And these individual projects generate value of their own. And the value that they deliver basically pays for the project itself. And that is how you get to a silent ICU, through individual steps that pay for themselves. And in conclusion, you can't get to silent ICU from 0 to 100. It's not a simple step. You need to have multiple self-contained projects that deliver quantifiable value that you can prove as value, and they are financed based on the value and the efficiencies that they deliver. And that is how you eat that elephant. So that is what I wanted to convey.